We've heard some arguments here today that if H.R. 3 were to become law, then there's a likelihood that innovation would be driven to China. I think that this is a red herring, let's be clear, because absolutely nothing in H.R. 3 is closing the U.S. market for drug manufacturers or drug development. The fact is that the United States is the largest pharmaceutical market in the world, and the pharmaceutical industry relies heavily on the premium academic institutions in the United States for their R&D work. There's no reason to believe H.R. 3 will fundamentally alter this dynamic. Innovation occurs where the best science is done, and the best science happens here in the United States of America. And there's no doubt that the U.S. will continue to be the world's leader in funding for basic medical science, and H.R. 3 provides additional resources to NIH to maintain our nation's role as a global leader in innovation. So Professor Sachs and Professor Karia, we've heard claims today that China can run clinical trials faster than U.S. counterparts. But does that mean they're better? Americans expect that the drugs that they and their families are going to take should meet rigorous review standards in order to ensure they are safe and effective. Do you agree that the Food and Drug Administration is the gold standard for drug approvals in the world? And whichever one of you wants to go first.
Yes, I do think that the US FDA is the gold standard for the world.
I agree
Professor
completely.
Sachs? Yeah. Additionally, Professor Sachs and Professor Carrier, isn't it fair to say that China pays relatively low prices for drugs? Why would we expect the Chinese market have greater innovation potential than the United States?
That's absolutely correct. China pays lower prices for drugs than we do. And I think you put it well when you said that innovation occurs where the best science is done, not where the drug prices are the highest.
Professor Carrier, any comments?
Sure. So I think that one issue that we haven't talked enough about is the type of innovation that would be affected by H.R. 3. So we're not talking about that many drugs. It's only 8 to 15 fewer drugs out of a total of 300, according to the studies. And if you look at the type of drugs here, they're not the most revolutionary drugs. So, for example, there is one study that just came out that looked at 122 ultra expensive drugs in Medicare, annual spending of $63,000 a year, and found that 73 to 85% of them have no or low additional added value. And so when we're talking about this, we're not talking about the blockbuster drugs. We're talking about a lot of Me Too drugs.
Well, let me ask you about that, because I hear from my constituents about the high cost of older drugs like albuterol. I mean, everybody on the committee knows that I cannot get the story of the mother out of my head who has to pay $800 for an inhaler. And so, for example, inhalers to treat asthma can cost hundreds of dollars, but they're decade-old drugs. Professor Sachs and Professor Carrier, how will the H.R. 3 framework incentivize new, innovative frontline treatments rather than the older Me Too drugs that you just discussed?
Well, it will force pharma to create new innovations. Pharma has played all sorts of anti-competitive games, and they've relied on those games, and they've relied on charging whatever price they want in the US, so they don't have to do quite as much innovation. Sure, innovation in the revolutionary kind is hard, but to the extent you can rely on these tricks that have gotten you to this point, then there's no need to go beyond that.
I agree. Yes, my apologies. I agree. If you look at the top selling drugs in Medicare right now, Part B and Part D, most of them are over a decade old. These are drugs that have recouped their investment and have had plenty of protected time on the market. Negotiating for the prices of these drugs won't harm innovation in the future. It'll make space for future innovation in just the way Professor Carrier said.